Treadmill stress echocardiography is typically performed to evaluate for exercise-induced myocardial ischemia. In addition to a standard exercise treadmill stress test, echocardiographic images are recorded at baseline and following stress. Ensure that the equipment and supplies needed for treadmill exercise echocardiography testing are present. This includes the treadmill, ECG monitoring machine, ECG acquisition module, blood pressure monitor, resuscitation capability, such as a crash cart, and the ultrasound machine. A qualified medical professional, such as a physician, nurse, or exercise technologist, is present throughout the study to monitor the patient. A cardiac sonographer is present to record the echocardiographic images. A brief history is taken to document symptoms, atherosclerosis risk factors, current medications, and basic laboratory findings. Review the clinical indications of the treadmill exercise ECG test, explain the procedure to the patient, and obtain written informed consent. Patients should refrain from oral intake 3 to 4 hours prior to the procedure. Medications which may impact maximal workload, such as beta blockers or calcium channel blockers, should be held for 1 to 2 doses unless the study purpose is to diagnose ischemia while on therapy or the risk of an adverse event off medication is deemed too high. In order to do the test safely, patients must be comfortable walking unaided on a treadmill. Patients are counseled on the risks of the procedure, such as angina or arrhythmia. Rarely, treadmill exercise ECG testing results in myocardial infarction, but the risk is less than 1%. Contraindications for this procedure include recent myocardial infarction, high-risk unstable angina, uncontrolled cardiac arrhythmias, symptomatic severe aortic stenosis or heart failure, and poorly controlled hypertension. Calculate the patient's target heart rate. Maximal predicted heart rate is calculated as 220 minus the patient's age. The target heart rate is 85% of the maximal predicted heart rate. In this case, based on an age of 58 years, the target heart rate 85% of 164, or 138 beats per minute. The patient is set up for monitoring. The physician or nurse supervising the procedure places ECG leads on the patient. Skin preparation with alcohol and gel improves lead contact, ensuring that leads will not dislodge during the study. The MD or RN reviews the baseline ECG for baseline abnormalities. Care should be taken to ensure a tracing from all leads with minimal artifact. The patient is positioned on the echo imaging bed in a left lateral decubitus position, and optimal ultrasound windows are marked lightly on the patient. Marks are used so that the same imaging window is used for comparison purposes at each stage. An adequate ECG signal is essential to ensure correct triggering of the digital cine loop acquisition. Several digital loops from each view are recorded. From these loops, the images that best show the left ventricular endocardial motion are saved. The ultrasound system is set up for recording images in a stress testing format. This allows echo images taken at rest and following peak stress to be displayed concurrently side by side to facilitate comparison. Images are acquired in standard image planes, typically the apical 4-chamber view, apical 2-chamber view, apical long axis view, and the parasternal short axis view. Recording the parasternal long axis view also may be helpful. If image quality is poor, this study can be performed concurrently with transpulmonary microbubble echo contrast to aid in left ventricular endocardial border definition as shown in this example. The ECG acquisition module is secured around the patient so that it does not become dislodged during treadmill use. It is critical that the post-exercise echo images be recorded as soon as treadmill exercise is discontinued. Myocardial ischemia may resolve if the delay between discontinuation of exercise and post-stress image acquisition is lengthy. Patients are counseled on the need for rapid transfer. Before treadmill exercise begins, the patient should perform a trial run of moving from the treadmill to the imaging bed to ensure that attached cords do not hinder transfer and to optimize patient positioning. The patient transfers to the treadmill and is asked to place his feet on either side of the belt prior to initiating the treadmill belt. A blood pressure cuff is secured on the patient. The patient is instructed to hold onto the treadmill bar to reduce the risk of falling. There are several exercise protocols used in clinical practice. We typically use the Bruce protocol, which is programmed to increase both in incline and speed in 3-minute stages. Blood pressure and heart rate are recorded at baseline and during the last minute of each stage. Periodically, the patient is asked if they are experiencing anginal symptoms. The patient is advised in advance when the treadmill will increase in speed and incline. During the study, the ECG is monitored for arrhythmia. Unless the patient is unable to continue the protocol, exercise is continued until at least target heart rate is achieved. Beyond target heart rate, patients are encouraged to continue exercise until fatigue or other symptoms necessitate exercise termination. If the patient does not achieve target heart rate, negative test results should be recorded as a non-diagnostic study in the context of the workload achieved. Treadmill exercise should be halted by the supervising provider with any development of severe angina, ataxia, dizziness, systolic blood pressures over 220 millimeters mercury, a hypotensive response or decrease in systolic blood pressure, concerning ECG changes, or significant arrhythmias. Once the patient indicates that they need to discontinue exercise, the technician quickly stops the treadmill without a cool-down period. The patient rapidly transfers to the echo imaging bed, and immediate post-stress echo images are recorded from echo views concordant with the resting images. Immediate post-stress imaging should be completed within 60 to 90 seconds of cessation of treadmill exercise. Blood pressure and heart rate are recorded, and the patient is asked about anginal symptoms. The patient is monitored until heart rate returns to baseline. If stress-induced ECG or echocardiographic abnormalities are seen, patients should be monitored until these abnormalities normalize. The ECG leads and IV lines are discontinued, and the patient is dismissed from the laboratory. The sonographer reviews digital loops from each view. The images that best show left ventricular endocardial motion are saved for comparison. Digital frame grabbers and split-screen displays allow side-by-side comparison of rest and stress images to facilitate identification of regional wall motion abnormalities. Digital frames are looped continuously for analysis. The physician interpreting the study reviews results. The physician reviews the side-by-side echocardiographic loops, evaluating for evidence of induced regional wall motion abnormalities. The heart rate and blood pressure response to dobutamine infusion are reported, along with any arrhythmias. Standard ECG criteria for ischemia are ST segment depression that is greater than 1 millimeter and horizontal or downsloping. Persists for at least 60 milliseconds after the end of the QRS complex. Is seen in 2 or more contiguous ECG leads. The stress test is considered abnormal if regional wall motion abnormalities are seen on the immediate post-stress echo images. This example shows normal wall motion at rest, with inducible ischemia in the anterior wall. Other abnormal findings included ECG criteria for ischemia, angina symptoms, arrhythmia, or if decreased exercise tolerance with a functional aerobic impairment that is 20% less than normal. A final report is generated which should include comment on exercise duration, workload achieved, description of symptoms during the study, hemodynamic findings during each stage, such as heart rate and blood pressure, echo results, and the ECG results.